on autosomal trisomies. So let's get started. Let's start with a flash case. Let's say a 39-year-old female presents to her primary care provider interested in starting a family with her new husband. She has heard that there is an increased risk of her child having Down syndrome because of her age and wants to know if it is true. She shows a picture of her brother and her 4-year-old niece with Down syndrome. So our learning objectives for this lecture are to explain non-disjunction and its role in the pathogenesis of autosomal trisomies, to differentiate the physical findings characteristic of Down syndrome, Edwards syndrome, and Patau syndrome, and to compare and contrast first and second trimester screening findings for Down syndrome, Edwards syndrome, and Patau syndrome. Okay, before we delve into the details about autosomal trisomies, we need to review what autosomal trisomy means. When do we use the term autosomal or autosome? Yep, usually we talk about it when we're talking about our chromosomes. We have autosomal chromosomes and we have sex chromosomes. So an autosome is simply a chromosome that is not an allosome or sex chromosome. Now remember, humans have a diploid genome, which consists of 22 pairs of autosomes and 1 pair of sex chromosomes, for a total of 46 chromosomes. And that's what we see in the image on this slide. Now that we have a basic understanding of some vocabulary, how would an autosomal trisomy occur? Well, we have to remember what normally occurs. Now, in meiosis 1, a diploid germ cell becomes 2 haploid cells, and you see the separation happening in this image. In meiosis 2, sister chromatids separate to form gametes, ready for fertilization. So, how could a trisomy occur? Well, what is a trisomy? It's when we have 3 instances of a chromosome instead of our regular 2. As we can see on this slide, things aren't separating the way they should. On the left, we see failure of homologous chromosomes to separate in meiosis 1. And on the right, we see failure of sister chromatids to separate in meiosis 2. And both of these failures of separation are known as non-disjunction. Again, failures of separation are known as non-disjunction. On the left, it's a failure of homologous chromosomes to separate, and on the right, it's sister chromatids. Now, as you can see at the bottom of this slide, this usually results in an abnormal distribution of chromosomes in our gametes. Enough of that review of basics. Let's move on to our most commonly known trisomies. The first is Down syndrome, or trisomy 21. Down syndrome is the most common viable chromosomal disorder and most common cause of genetic intellectual disability. Its incidence is 1 in 700. 95% of cases are due to meiotic non-disjunction, which increases with advanced maternal age. The rate is drastically different for younger women or older women. It's approximately 1 in 1,500 in women less than 20 years old, and 1 in 25 in women greater than 45 years old. The second most common cause can be seen in about 4% of our cases, and these are due to an unbalanced Robertsonian translocation, most typically between chromosomes 14 and 21. Now, only 1% of cases are due to a post-fertilization mitotic error. Well, how do the patients present? The most common clinical findings in a patient with Down syndrome are intellectual disability, flat facies, prominent epicanthal folds, a single palmar crease, as we can see in this image, an incurved fifth finger, a gap between the first two toes, duodenal atresia, Hirschsprung's disease, congenital heart disease like an atrial septal defect, and brush field spots that are noticeable in the eyes. Now, these are all extremely high yield because the vignette you may see is very likely to have multisystemic presentations, like a gastrointestinal obstruction or a murmur. In addition, Down syndrome is associated with early onset Alzheimer's disease, since chromosome 21 codes for our amyloid precursor protein. Also, patients with Down syndrome are at increased risk of AML or ALL. Findings on first trimester ultrasound commonly show an increased nuchal translucency and a hypoplastic nasal bone. Here in this image, we can see a nuchal translucency scan, which is a prenatal screening ultrasound. As nuchal translucency size increases, the chances of a chromosomal abnormality and mortality increase, and it's measured where the arrow is pointing to. The markers for Down syndrome show increased HCG and increased inhibin, and a mnemonic we can use to remember that is the markers for Down syndrome are high up. Another helpful mnemonic for Down syndrome are the 5 A's. Those 5 A's are advanced maternal age, duodenal atresia, atrioventricular septal defects, early onset Alzheimer's disease, and an increased risk for AML or ALL. The next trisomy we'll discuss is trisomy 18 or Edwards syndrome. Now, Down syndrome has a much higher incidence with 1 in 700 compared to Edwards syndrome, which occurs in 1 in 8,000, but it is the second most common autosomal trisomy that results in a live birth. Now, unfortunately, death usually occurs by 1 year of age. The clinical findings can be conveniently summarized with the mnemonic Prince Edward. The P stands for prominent occiput, the R for rocker bottom feet, the I for intellectual disability, the N for non-disjunction as a cause of trisomy, as we discussed before, the C for clenched fists with overlapping fingers like in this image, and the E for low-set ears. Infants born with Edwards syndrome also can present with micrognathia, or a small jaw, congenital heart disease, omphalocele, and myelomeningocele. Next, we have trisomy 13, or Patau syndrome, which is even more rare, with an incidence of 1 in 15,000. In Patau syndrome, there is a defect in fusion of the precordial mesoderm that results in midline defects, and death usually occurs by age 1. Now, some of the findings are similar to Edwards syndrome that we just talked about, like severe intellectual disability and rocker bottom feet. So if a vignette is trying to get you to diagnose Patau syndrome, they're going to have to give you a more distinguishing characteristic. One of them is microophthalmia, or very small eyeballs, and microcephaly. The other findings have P in them to help you remember P for Patau syndrome. They include a cleft lip and palate, holoprosencephaly, polydactyly, cutis aplasia, which can be seen in this image, which is basically absent hair or skin in that area. And other findings can include congenital heart disease or a pump disease, to start with P, polycystic kidney disease, and omphalocele. As you may be aware, USMLE loves asking questions with arrows and tables, which is a great way to test your understanding of markers, hormones, electrolytes, and pathophysiology. In a first trimester screening, we look closely at beta-HCG and PAP-A, which stands for Pregnancy-Associated Plasma Protein A. Low plasma levels of PAP-A is a biomarker for aneuploidy, or an abnormal chromosome number, so it will be decreased in all three of the trisomies we just discussed. Beta-HCG will also be increased in the first trimester screening, except in Down syndrome, because remember our mnemonic that the markers for Down are high, or increased. And H in HI stands for HCG, and I stands for what again? Yep, it stands for inhibin A, which we can see in the second trimester screening. Both beta-HCG and inhibin A are increased. The second trimester screen is often called the triple test to help determine if a patient has a fetus with a high or low risk for chromosomal abnormalities and neural tube defects. And the triple test includes alpha-fetoprotein, or AFP, estriol, and beta-HCG. It is known as a quad screen or quadruple test if inhibin A is added to increase sensitivity and decrease our false positive rate. I know there are a lot of arrows and numbers on here, but just remember, the legal drinking age in the United States is 21, the election age, or age when you can vote, is 18, and the approximate age for puberty is 13. D for Down syndrome, E for Edward and chromosome 18, and P for Patau and chromosome 13. Alright, let's do a flash quiz. Edward syndrome is an autosomal trisomy of which chromosome? Great, it's chromosome 18. Let's try another one. What are the two main causes of the autosomal trisomy in Down syndrome? Non-disjunction and Robertsonian translocation. Great job. Well, let's get back to the case. Is there an increased risk of having a child with Down syndrome because of maternal age? Yes, there is. Remember that 95% of cases of Down syndrome are due to meiotic non-disjunction, which increases with advanced maternal age, from 1 in 1,500 in women who are less than 20 to 1 in 25 in women greater than 45 years old. This is really important for patient counseling and family planning. So our bottom line today is that Down syndrome, or trisomy 21, is the most common viable chromosomal disorder and most common cause of genetic intellectual disability. Edwards syndrome, or trisomy 18, is the second most common autosomal trisomy resulting in a live birth. And Patau syndrome, trisomy 13, is a rare autosomal trisomy that results in live birth. Well, that's all I have for you here. Please give this video a thumbs up if you liked it, and it'll give you the opportunity to submit a comment if you have any feedback or questions. Thanks for joining me. Study hard.